welcome everybody. Now we will continue part 3 of ulcerative vesicular and bullous lesion. Now we will talk about patient with recurring oral ulcer. Recurrent oral ulcer is a major problem seen by clinician in the oral medicine clinic because we can always see patient attending the clinic about having recurrent oral ulcer. There are many diseases included in the differential diagnosis of recurrent oral ulceration. These are recurrent aphthous stomatitis, Burket disease or syndrome, and recrudescent herpes simplex virus infection and recurrent oral erythema multiforme. Recurrent aphthous stomatitis is a common disorder characterized by recurring ulcer restricted to the oral mucosa, but there should be no other sign and symptom of other systemic disease. So to say that this patient have recurrent aphthous stomatitis, there should no other sign and symptom of other systemic diseases. Hematological deficiency, immune disorder, connective tissue disease, all these may be associated with this type of stomatitis. Recurrent aphthous stomatitis affects 20% of general population. Those with a specific ethnic or socioeconomic group may have more than this percentage, may have up to 50% of patients as having this type of stomatitis. Clinical characteristic of aphthous stomatitis, it is minor, major, or herpetiform. Patient experience severe discomfort from continuous episode of ulcer, may be severe, may be mild. So, what is the etiology and pathogenesis of the recurrent aphthous stomatitis? Previously, many clinicians mistakenly called recurrent aphthous stomatitis as a herpes. There are many factors or major factors linked to the recurrent aphthous stomatitis. These may include genetic factor, hematological, immunological abnormality, and maybe local factors such as trauma and smoking. Also, evidence increased the association between local immune deficiency and recurrent aphthous stomatitis. Also, research showed that recurrent aphthous stomatitis and lymphocytotoxicity, antibody-dependent cell-mediated cytotoxicity, and there is a defect in lymphocyte cell subpopulation. There is also a defect in or alteration in CD4 to CD8 lymphocyte ratio. All these factors may be associated with the recurrent aphthous stomatitis. Also, evidence showed that there is an inherited nature of this type of stomatitis. A study showed that there is a genetically specific human leukocyte antigen HLA identified in patients with recurrent aphthous stomatitis in specific ethnic. Also, many studies recently showed uh, linking of the minor aphthous ulcer to genetic factor associated with immune function. But the most widely accepted idea about the association between recurrent aphthous stomatitis with hematological deficiency, serum iron, folate, uh, B12 to be linked to patient with aphthous like ulcer. And these mostly seen in keratinized mucosa. Also, there is alpha-spike ulcer in patients with celiac disease. But there is a negative correlation between recurrent aphthous ulcer and history of smoking. They found that when patients stop smoking, the recurrent aphthous stomatitis is stopped or increased. So stop smoking associated with an increased incidence of recurrent aphthous stomatitis. Also, a study measuring nicotine metabolite in a smoker in the blood of a smoker showed a significant lower among smoker patients. That's mean recurrent aphthous stomatitis is lower in a smoker patient compared to non-smoker because of the nicotine metabolite found in the blood of the smoker. This metabolite related to nicotine material decrease the level of pro-inflammatory cytokine and increase the anti-inflammatory cytokine. So decrease pro-inflammatory and increase the anti-inflammatory. Okay. Also, there is a relation or association between anxiety, uh, psychological stress, localized trauma, menstruation, upper respiratory tract infection, and also food allergy. All these factors may be associated with recurrent aphthous. What is the oral finding of recurrent aphthous stomatitis? It is mostly seen in the second decade of life. There is prodromal burning sensation uh, followed by after 2 to 48 hours by the appearing of ulcer. Is localized, associated with localized erythema. Within the next 48 to 72 hours, the ulcer gradually get increased in size. So, how we can describe the aphthous ulcer? It is round, symmetrical, shallow ulcer, but there is no tissue tags at the border of the ulcer, which is which is differentiated this type of ulcer from the viral ulcer, because viral ulcer always there is a vesicle ruptured and then develop ulcer. Okay, maybe multiple lesion or maybe one lesion, different in the size of the lesion, maybe small, maybe medium, maybe large ulcerated area. In mild, the size of the lesion 0.3 to 1 centimeter, healing within a few days. Healing without scarring is usually complete in 10 to 14 days, but a patient with recurrent aphthous stomatitis may have one or six lesions at each episode and experience several episodes a year. So this is what we call recurrent aphthous stomatitis. We should have one to six lesions and the in each episode, and there is several episodes in a year. The disease is an annoying for the majority of patients, and patients feel unable to eat, and there is pain in the ulcer. Sometimes need medication. The major aphthous ulcer may be larger than 1 centimeter and may last for weeks or even months. It is deep ulcer and interfere with speech, with eating, and even with the swallowing sometimes when it is in the posterior part of the tongue. Sometimes the patient needs hospitalization for the intravenous fluid and also systemic corticosteroid. The lesion may last for months to heal, Therefore, it may be misdiagnosed with squamous cell carcinoma or blistering disease because the lesion slowly healed, leaving a scar and maybe lead to a decreased mobility in the tongue. Uh, this will be make the talking, the eating, and also swallowing difficult. The uh, least common variant of recurrent after ulcer is the herpetiform type. Occur in the adult. It may be more than 10 small ulcers measuring less than 5 millimeter scattered all over the affected oral. Laboratory investigation should be ordered only uh, when there is a problem with the diagnosis. How we can find there is a problem in the diagnosis? When the episode of recurrent ulcers become more severe, when the patient past the 40 years of age, and when there is other associated sign and symptom. Biopsy are only indicated when it is necessary to exclude other systemic disease such as Crohn's disease, sarcoidosis, blistering disease such as pemphigus, pemphigoid, or when we see a dirty looking ulcer such as in case of squamous cell carcinoma. So when we need to exclude the other type of disease, systemic disease, and squamous cell carcinoma, we order a biopsy. But otherwise, clinical feature, history of patient is enough to do investigation. Patient with severe minor aphthous or major aphthous should be investigated for, as I said, for other systemic disorder such as connective tissue, hematological disease, such as serum iron deficiency, folate, vitamin B12, ferritin, or other associated systemic diseases. Patient with AIDS, HIV infected patient, and mostly those with CD4 count less than 100 per millimeter cubic millimeter may develop major aphthous ulcer, and this is maybe oral presenting sign of the AIDS patient. Biopsy reveal only a superficial ulcer covered by a fibrinous exudate with a granulation tissue at the base and at the base of the lesion there is a mix of acute and chronic inflammatory cell infiltration. So it is non-specific in the biopsy. Now, what is the management of recurrent upper stomatitis? Mainly, the management to relieve pain, and we can use topical anesthesia. In severe cases, high potency topical steroid may be used to shorten healing time and reduce the size of the ulcer. Effective topical steroid based on a good instruction and patient complaint regarding proper use. The steroid gel should be applied directly on the lesion, and that will be after the meals and at bedtime 2 to 3 times a day, or can may be mixed with an adhesive such as Orobase prior to application. The most widely used is the Kinalog in Orobase. Larger lesion can be treated uh, by using the gauze sponge. So this spongy gauze leaving on the ulcer in a place for 15 to 30 minutes to allow a longer period of time of the contact of the medication to Also, intralesional steroid injection may be used for those patients who have a lesion which is reluctant. What is a reluctant lesion? Lesion that resists the treatment and unable to heal. So this type of lesion need to have another medication, not just a topical steroid. This will have, for example, intralesional steroid, as I said, or maybe systemic application of steroids. Other medication may be used for those patients for those ulcer that unable to heal for the ordinary time, such as colchicine, dapsone. These uh, medication uh, decrease the amount of using the steroid. So use a combination of steroid with a lower doses and this type of medication in such patient that when they have ulcer, unhealed ulcer for long period of time, or what we call it a reluctant ulcer, resistant to treatment, resistant to heal. Okay. One of the medication that can be used in treating major aftas ulcer and also treating other type of ulcer is the thalidomide. Why why I we should hear thalidomide used when there is a fail to control for the major aftas ulcer by other medication. So thalidomide is a serious type of medication. It is not a simple medication because it is uh, causing the forming birth defect because it is a teratogenic, has a teratogenic effect. So all clinicians prescribing thalidomide in the United States, for example, should register in a risk evaluation mitigation strategy program. Any patient receiving this type of medication should have should have, for example, two methods of birth control, mean contraceptive, two type of they should use a two type of contraceptive, and the patient must have a pregnancy test monthly. Okay, so because this type of medication includes uh, many side effects such as peripheral neuropathy, gastrointestinal complaint, drowsiness, deep venous thrombosis, and other side effects. So those patients on long term of thalidomide should be monitored to be away from the severe life-threatening and deforming birth defects. Okay. Now we will talk about the Behçet syndrome. Behçet syndrome is a trait of symptom including recurrent oral ulcer, recurrent general ulcer, and eye involvement. Behçet disease is a multi-system disorder. It is more severe in younger patients, and eye and GIT involvement may have seen. Etiology and pathogenesis. Behçet syndrome is a systemic vasculitis. It is a systemic vasculitis characterized by hyperactivity of neutrophil with enhanced chemotaxis and elevated pro-inflammatory cytokines, interleukin 8, interleukin 17 with tumor necrosis factor alpha, all these playing a major role in the pathogenesis. So it is a systemic vasculitis, and there is an elevation in pro-inflammatory cytokines such as interleukin 8, interleukin 17, tumor necrosis factor alpha. Human leukocyte antigen B51 genotype is the most frequently type of antigen linked to Behçet syndrome, especially in the patient with a severe form of Behçet syndrome in Asia. What is the clinical manifestation of this disease? The highest incidence in adult patients in 25 to 40 years. Oral mucosa is the most common site of involvement. The genital area, the second most common site involvement. Eye lesion also consists of uveitis, retinal vasculitis, vascular occlusion, optic atrophy, and conjunctivitis. Blindness is a common complication of the disease. So there is a need for a periodic evaluation of such type of patient is very necessary. Systemic involvement can be seen in 50% of patients with Behçet disease. Skin involvement, for example, erythema nodosum or a large osteal lesion. The lesion may be precipitated by trauma, and it is a common in patients with continuous hyperactivity to continuous injection or needle stick pathology. Arthritis can be seen in 40% of patients with Behçet disease, mostly affecting the knee, ankle, wrist, and elbow. These joints become red, and also some patients may have a central nervous system involvement. Sometimes they have thrombophlebitis, intestinal ulceration, venous thrombosis, renal, cardiac, and pulmonary diseases. Both pulmonary involvement and cardiac involvement are believed to be associated with secondary vasculitis, involving the large vessel, which is life-threatening and lead to arterial occlusion or aneurysm. Behçet disease in children, most frequently seen in patients between 9 and 10 years of age. Similar manifestation to the Behçet disease in adults, but oral ulcers are more common, presenting time in children, whereas uveitis is less common. Oral lesion seen in more than 95% of children. A variant of Behçet disease characterized by mild genital ulcer with inflamed cartilage is associated with relapsing polychondritis of patients. Oral findings, as we say, oral lesion, recurring oral ulcer in more than 90% of patients. These lesions can't be distinguished from recurrent upper stomatitis clinically or histopathologically. Some patients experience mild recurring oral lesion, others have deep large scarring lesion, similar to the major recurrent upper stomatitis. These lesions may appear anywhere in the oral cavity or pharyngeal mucosa. Laboratory findings depend on the clinical diagnosis criteria. Laboratory tests may be used to rule out other diseases, in another word, to exclude other connective tissue diseases such as lupus, hematological diseases that causing severe immunity. Now, what is the management of patients with Burket disease? The management depends on the severity and the site of involvement. Patients with life-threatening disease, central nervous system, sight-threatening eye involvement, need aggressive therapy. However, there is a serious side effect from the medication, but because the disease is severe, this medication should be used, with such as azathioprine may be used, pentoxyphylline, systemic steroid, dapsone, progestin, and thalidomide. Also, monoclonal antibody such as etanercept may play a role in the therapy of Burket disease, mostly in patients who don't respond to the anti-inflammatory and immunosuppressive. Now we will talk about the patient with chronic multiple ulcer. Now, chronic multiple ulcer. These are pemphigus vulgaris, paraneoplastic pemphigus vulgaris, pemphigus vegetans, subepithelial bullous dermatosis, bullous pemphigoid, mucous membrane pemphigoid, cicatricial pemphigoid, linear IgA disease, and chronic bullous disease of childhood, and finally epidermolysis bullosa acquisitia. We will start with the pemphigus. Pemphigus include a group of autoimmune, potentially life-threatening disease causing blister, erosion of the skin and mucous membrane, characterized by intraepithelial acantholysis. The predisposing to develop the autoantibody to cause pemphigus is genetically determined, but a triggering mechanism initiate the immune system is unknown. The pathogenesis of the pemphigus, including the following: Dismo, dismoglo, dismolin, dismoglin 1 is a glycoprotein adhesion molecule, is mostly found in the skin, whereas dismoglin 3 is chiefly detected in the mucosal epithelium. Individual genetically susceptible to pemphigus harbor dismoglin reactive B anti-cell. Now, we should know that the DSG1 found where in the skin, and DSG3 found in the oral mucosa. Okay? The immune reaction against this glycoprotein cause loss of cell-to-cell adhesion, resulting in separation of the cell from each other and formation of the intraepithelial bullae. So, the cell attached to cells by the DSG1 and DSG3. Autoantibody in pemphigus diseases destroy this adhesion, leading to formation of intraepithelial bullae. This is the pathogenesis. Now we will start with pemphigus vulgaris. Etiology and pathogenesis of this type of pemphigus. It is the most common pemphigus, can be seen in 80% of cases. The underlying mechanism responsible for the intraepithelial lesion is the binding of IgG autoantibody to DSG3. The loss of this glycoprotein results in loss of cell-to-cell adhesion, which lead to intraepithelial blister. Patients with pemphigus vulgaris have antibody primarily against DSG3, which involving the skin, and have antibody against DSG1 involving the oral mucosa. Pemphigus vulgaris may be reporting with other autoimmune diseases. Several cases of pemphigus reported in patients with autoimmune disorder or those with neoplasm such as lymphoma. The death most frequently occur in elderly patients and patients requiring high dose of corticosteroid. They develop infection and bacteria leading to septicemia, which is most noticeably from the Staphylococcus aureus. A characteristic sign of this disease is by obtaining a pressure to an intact bully. The patient bully enlarged by extending to an apparently normal surface. Another characteristic sign of this disease is that the pressure to an apparently normal area results in the formation of a new lesion. This phenomenon, called the Nikolsky sign, result from the upper layer of the skin pulling away from the basal layer. Any mucosal and the skin surface may be involved, and in severe cases, the conjunctival, pharyngeal, laryngeal mucosa may be involved with an extensive skin lesion. Patients with oral lesion may also have esophageal uh, lesion, and if the esophageal symptoms are present, endoscopic examination should be performed to determine the severity of what is the oral finding in these cases. Up to 80 to 90% of patients develop oral lesion in their course of the disease, but only in 60% of cases oral lesions are the first sign of the disease. Oral lesion may begin as a classical bully on a non-inflamed base. More frequently, clinicians see a shallow irregular erosion and ulcer because the bully rupture quickly in the oral cavity. A thin layer of epithelium peel away in an irregular pattern, leaving a denuded base. The age of the lesion continue to extend peripherally over a period of weeks until they involve larger portion of the oral mucosa. Most commonly Usually the lesions start on the buccal mucosa and mostly in the area subjected to trauma along the occlusal plane. Palatal mucosa, gingiva are other common site of involvement. It is common for the oral lesion to be present for months before the skin lesion to frequently, however, the initial diagnosis is missed and the lesion misdiagnosed as herpes simplex virus infection or candidiasis. The average time from the disease onset to diagnosis may take over 5 months, and coexisting candidiasis may mask the typical feature of the pemphigus lesion. There is a small subgroup of pemphigus patients whose disease remains confined to the oral cavity. These patients often have a negative result on indirect and direct immunofluorescent testing for that use. Laboratory finding and pathology. Pemphigus vulgaris is diagnosed by a biopsy, and biopsy are best done on intact vesicle and fully less than 24 hours old. However, intact lesions are rare on the oral mucosa because of rupture, quickly ruptured. The biopsy specimen should be taken from the advancing age of the lesion, where the area or characteristic supra-basilar condylosis may be the observed pathological sign. Specimens taken from the center of the denuded area are non-specific histologically. So, as any biopsy, we should take it from the periphery of the lesion, not from the central of the lesion. Sometimes more than one biopsy is necessary to make the diagnosis. These two pictures show the pemphigus vulgaris in the ventral surface of the tongue and in the lower anterior gingival. Now, what is the management of pemphigus vulgaris? Early diagnosis and lower doses of medication, shortening the period of time is important for the controlling of the disease. Management depends on many factors, including severity and the speed at which the disease progresses. Treatment mainly on high doses of systemic steroid, and the dosage is 1 to 2 milligram per kg body weight. When the steroid medication is needed for a longer period of time, another medication should be used because we need to reduce the steroid doses to reduce the serious side effects of this type of medication. So using another medication such as immunosuppressive medication, azathioprine, cyclophosphamide, cyclophosphamide plus therapy, azathioprine, these type of medication used with steroid, so to reduce the dose of steroid. If we use the steroid only, we need high doses of steroid, and that will cause a big damage to the organ of the body of the patient. So using a combination of this medication with the steroid, reducing the doses of steroid, reducing the side effect of steroid in the same time. Prednisolone is used initially to bring the disease under control, and once the disease achieves the doses of prednisolone decrease to the lowest possible maintenance doses or level. Patient only with oral involvement may need lower doses of prednisolone for a shorter period of time, and the clinician should wait between the benefits of the doses of the medication, and the using of adjunct therapy to reduce the risk of long-term immunosuppression from the steroid. A blood dyscrasia and increased risk of malignancy may be a side effect of using this medication. So using this medication should be in a balance between the severity of the disease, systemic health of patient, and other factors should be. Most study of pemphigus vulgaris always skin showed a decreased mortality rate when using other adjunctive therapy. When we need to use the prednisolone or the corticosteroid in general for a longer period of time. The need for systemic steroid may be lowered further in cases combining with other systemic therapy, but allowing the prednisolone tablet to dissolve slowly in mouth before swallowing, or by using high potency topical steroid cream may be a useful method. Dapsone may be used and show an effective results. Reluctant cases are treated with rituximab and intravenous immunoglobulin. Rituximab is presently or recently used as a first line of treatment, although study demonstrates a high rate of infection associated with rituximab. Okay, used. Now we will talk about the bullous pemphigoid. Bullous pemphigoid, the most common of subepithelial blistering disease, chiefly found in adults older than the age of 60. It is self-limiting and may last for a few months to 5 years. It may cause death in older deputated individual, although evaluation for an underlying malignancy is recommended for patients with severe or reluctant bullous pemphigoid. Bullous pemphigoid is an autoimmune disease caused by the binding of autoantibody to a specific antigen found in the lamina lucida region of the basement membrane on the hemidesmosome of the epithelial basal cell. These antigens are glycoprotein referred to as bullous pemphigoid antigen 180 and 230. Binding of the antibody to antigen activated both leukocyte and complement, causing localized damage to the basement membrane, resulting in vesicle formation in the subepithelial region. Sub Clinical manifestation of bullous pemphigoid is a tense blister on the inflamed area. Tense blister on inflamed area accompanied by urticarial plaque in the scalp, abdomen, extremities, axilla, and front. Pruritus is a common feature of the skin lesion. The disease is self-limiting but can last for months to years without therapy. Patients with bullous pemphigoid may experience one episode or recurrent uh, recurrent lesion. Unlike pemphigus, bullous pemphigoid is rarely life-threatening since apulli don't continue to extend at the periphery to form larger denuded area. Death from sepsis or cardiovascular disease secondary to long-term steroid use has been reported to be high in a group of sick elderly patients. Oral finding: 10 to 20% of patients have an oral involvement. Oral lesions are smaller, more slowly, less painful than the pemphigus vulgaris. Often extensive labial involvement seen, and pemphigus vulgaris is not present. Desquamated gingivitis has also been reported as a most common oral manifestation of bullous pemphigoid, and the gingival lesion may be the only site of oral involvement. The gingival lesion consists generalized edema and inflammation, desquamation, and may be just a localized area of vesicle formation. Oral lesions are clinically and histologically indistinguishable from the oral lesion of mucous membrane pemphigoid. Laboratory finding: routine histology of specimen demonstrate separation of the epithelium from the connective tissue at the basement membrane zone, and the inflammatory infiltrate that is usually rich in eosinophil, particularly in the skin biopsy. Management: localized oral lesion may be treated with high potency topical steroid such as fluticasone or betamethasone, whereas patients with more extensive disease may need systemic corticosteroid alone or combined with other immunosuppressive medications such as azathioprine, cyclophosphamide, or mycophenolate or rituximab. Patients with moderate level of disease may minimize the use of systemic steroid by using dapsone or tetracycline, doxycycline, or minocycline, which may be combined with niacinamide, this type of medication. A mucous membrane pemphigoid or cicatricial pemphigoid is chronic autoimmune subepithelial disease that primarily affects the mucous membrane in patients older than 50 years of old. The lesion appear as mucosal blistering, ulceration, and subsequent scarring in some organ. The disease occurs twice as frequently in women, so it is more common in women than men. The primary lesion occur when there is autoantibodies directed against the protein in the basement membrane zone acting with complement C3 cause a subepithelial split and subsequent vesicle formation. Antibodies against the basement membrane antigen have identified in cases of mucous membrane pemphigoid. The antigen most frequently present in lamina lucida of the basement membrane, but the lamina densa may be the primary site of involvement in some cases. Oral finding: oral lesion seen in more than 90% of patients. The sequelative gingivitis is the most common manifestation and may be the only manifestation of the disease in the appearing in bright red. Since these desquamated lesions resemble the lesion of erosive lichen planus and pemphigus vulgaris, all cases of desquamated gingivitis should be biopsied and studies with both routine histology and direct immunofluorescence for definitive diagnosis. The lesion may present as intact vesicle of the gingiva or other mucosal surface, but more frequently appear as a non-specific appearing erythema and erosion. Unlike pemphigoid or mucous membrane pemphigoid, rare, unlike ocular pemphigoid, mucous membrane pemphigoid rarely heal with scarring. Okay. Laboratory finding: patient suspected with a mucous membrane pemphigoid should be biopsied taken for both routine biopsy and direct immunofluorescence study. The specimen for routine histology and direct immunofluorescence should be taken from the edge of an ulcer, vesicle, or erythematous tissue. The histopathology reveals subepithelial clefting with preserving of the basal cell and variable degree of inflammation. Now, what is the management of mucous membrane pemphigoid? This also depends on the severity of the symptom and the site of involvement. When it is confined to the oral mucosa, use systemic corticosteroid may be only considered for the short period of time for severe outbreak until steroid sparing therapy can be instituted. Unlike bullous pemphigoid, mucous membrane pemphigoid, rarely fatal disease, and long-term use of systemic steroid for oral lesion involvement alone is seldom indicated. Patients with mild oral disease may be treated with topical and intralesional steroid to be away from the systemic steroid. So, what is the steroid sparing therapy? Because the disease can persist throughout the lifetime, to control and minimize the toxicity related to immunosuppression agent, a steroid sparing agent in the management of a patient with autoimmune bullous disease is important. This means that we use another medication, adjunctive therapy, we call it also, to minimize and reduce the side effects of steroid. Vesicular gingivitis can be also managed with topical steroid in a soft dental supplement that cover the gingiva. Also, using topical steroid for larger area of mucosa must closely monitor the patient for the side effects such as candidiasis and effect of the systemic absorption. When the topical or intralesional steroid is not successful, use of tetracycline, doxycycline may be helpful in controlling the vesicular gingivitis and other oral lesions. When there are severe oral lesions, uh, dapsone therapy or other anti-immunosuppressive medication may be used as a next step for considering long-term systemic steroids such as rituximab or other dapsone or other antidepressant, anti-immunosuppressant medication. Since the dapsone cause hemolysis and methylglobulin, glucose 6 phosphate dehydrogenase deficiency must be ruled out and the patient hemoglobin must be closely monitored. Okay, so using topical steroid for longer period of time is not away from the serious side effect of corticosteroid. Okay, so because the absorption from the from the oral mucosa is not easy, yeah, not few. It is there is a good absorption from the oral mucosa. Okay. Now we will talk about the epidermolysis bullosa acquisition. Patients with epidermolysis bullosa having IgG antibodies directed against type 7 collagen. This collagen is a component of anchoring fiber of the basement membrane. There are two forms of epidermolysis bullosa. The classic form, which results in a lesion of the basement membrane with little inflammation, or the inflammatory form, which include a significant infiltration of a neutrophil. What is the clinical manifestation? It is resembling the bullous pemphigoid, mucous membrane pemphigoid, with a widespread skin lesion or a primary involvement of the oral mucosa, genital mucosa, conjunctiva, and larynx. Oral lesion appear as erythema, erosion, ulcer, and desquamative gingivitis. Now, what is the management of epidermolysis bullosa? The management depending on the severity and the extent of the clinical lesions. The classic form of the disease tend to be resistant to the treatment, whereas the inflammatory form respond well to the dapsone. Systemic corticosteroid, immunosuppressive medication, or intravenous IgG may be required to control the lesion in severe widely spread epidermal. Okay? Now we will talk about the last uh, classification of the vesicular bullous lesion, which is patient with single ulcers. Patient with single ulcer. We have first a traumatic injury causing solitary ulceration, traumatic ulceration granuloma, which is called eosinophilic ulcer of the tongue, and infectious ulcer. We will start with the traumatic injury causing solitary ulceration. Etiology and pathogenesis. It is a single mucosal ulcer, may be caused by direct physical, mechanical, thermal, chemical, or even vascular component, causing tissue damage and ulceration. Acute bite injury, example of a direct physical mechanical trauma, may always often can be seen in the oral cavity. Traumatic injury may result from malocclusion, opening dental prosthesis, overuse of toothbrushing, flossing, self-injury habits, and oral piercings. Thermal injury may include electrical burn, frequently seen in children who inadvertently chew or electrical wiring. More commonly, thermal burn can seen in the rectal mucosa from ingesting hot food and beverage, mostly seen in hot pizza or coffee. An atherogenic cause of thermal injury is often happen with heated dental instrument. Chemical trauma may be caused when in clinic when the dentist placing noxious and caustic substance directly on the mucosa, or chewing medication before swallows, for example aspirin or bisphosphonate, may also lead to a severe mouthwashes, other oral care or products with high alcoholic content, hydrogen peroxide, phenol, used too frequently to or undiluted can cause mucosal ulceration. If it is used undiluted, also may cause mucosal ulceration. Some over-the-counter medication for treating aphthous ulcer contain high concentration of silver nitrate, phenol, or sulfuric acid, should be used with caution. Ulcer have also resulted in use of denture cleaner as an oral rinse. A prolonged contact with monomer from the acrylic material on the mucosa may also lead to necrosis of the mucosa. Necrosis of the bone and mucosa has been reported from chemical use in endodontic if these are pushed out the apex of the tooth. In other words, mean over if it is overextended of the apical foramen. Vascular comprises lead to oral ulcer, may be seen in two patterns. Necrotizing cyalometaplasia, where there is a local infarction of the salivary gland tissue leading to overlying ulceration, exfoliation of the necrotic tissue, and healing. Many etiology have been identified in vasoconstriction, sustained pressure, and bulimia, and the most common location of these conditions is the heart palate. Although the location may contain any salivary gland, any minor salivary gland in the oral cavity. Another is systemic vasculitis, where the inflammation of vessel lead to thrombosis and infarction. Tongue necrosis is a particularly well documented aspect of giant cell arthritis. What is the management of such condition? If smaller lesions heal by their own, there is no need for any medication. But this will heal when we remove the cause, the irritant. Pain can be controlled by topical anesthesia, such as viscous lidocaine. Topical steroid, intralesional steroid may also be useful. Dentists should be aware from using material such as caustic substance and heated instrument to be aware from this type of lesion. Electrical burn goes deep and more extensive and may lead to scarring and contracture. If the corner of the mouth are involved, microstomia may result. Children benefit from the use of microstomia prevention device during this healing period, although surgical correction may still be required to restore the function and the aesthetic of the oral cavity. Antibiotic may be necessary to prevent the secondary infection. This lesion may take several weeks to heal. Necrotizing cytometaplasia also on its own heal on its own, while ulcer of the vesiculitis origin will generally require treatment with systemic corticosteroid. Now we will talk about the traumatic ulcerative granuloma, eosinophilic ulcer of the tongue. What is the etiology and pathogenesis of this granuloma? This ulcerative condition of the oral cavity is considered traumatic in nature, although less than 50% of patients recall a history of a trauma. It is likely that penetrating nature of the inflammation result in myositis that lead to the chronicity. Other acute or chronic ulcerative conditions, if left untreated, may become deep and penetrating. Similar lesions are seen on the ventral tongue in the infant caused by the tongue grasping against a newly erupted primary incisor, a condition known as Raji-Fed disease. Patient with familial dystonia clinical manifestation. It is a bimodal age distribution. First 2 years of life associated with erupting primary dentition, adult in fifth and sixth decade of life. Oral finding in the children, there is ulcer always in the anterior, ventral, or dorsal surface of the tongue, associated with erupting mandibular or maxillary incisor, respectively. The tongue is the site of involvement. Approximately 60% of adult cases, usually on the posterior and lateral aspect. The ulcer develop may be not painful in the two-thirds of cases and may persist for months. A history of trauma in between 20 to 50% of cases The ulcer generally appear cleanly punched out with surrounding erythema and keratosis if it is present for weeks or months. A single chronic painless ulcer with any duration raise suspicious for squamous cell carcinoma, especially if it is on the tongue, salivary gland malignancy, or lymphoma. So, management of such condition, taking a careful history, is very important to rule out uh, continued trauma to the site. Intralesional steroid may be performed over a few weeks if it is lesion stay for a long period of time. Wound debridement also lead to complete resolution in one-third of cases. The use of night guard on lower teeth may help to reduce the nighttime trauma. Now, we will talk about the infections causing solitary ulcer. Viral infections such as cytomegalovirus, Epstein-Barr virus, or herpes virus may cause single ulcer that last for weeks or months in the immunocompromised or immunocompetent patient. The deep mycosis were uncommon cause of oral lesion prior to HIV infection, chemotherapy, immunosuppressive drug medication. The dentist must consider this group of disease in the differential diagnosis whenever there is isolated ulcerative oral lesion developed in none or suspected immunosuppressive patient. If there is reactive epithelial hyperplasia to the organism, lesion may appear as fungated masses resembling squamous cell carcinoma. Biopsy of suspected lesion accompanied by requested for appropriate stent is necessary for early diagnosis and the final diagnosis.